My name is Philip Meese. I'm a rheumatologist from Seattle, and we are going to be, up until lunchtime, conducting a workshop on pain. The content we're going to do some plenary initially, orienting you to what some of the key subject areas that we want to discuss during the breakout groups. We'll go to the breakout groups and discuss, and then come back and review all that we have discussed, and then moving forward. Here is our group. Many of these faces are very familiar to you, including Dorcas, Peter Tugwell, smiling as usual, and Tim Pickles, who is our fellow from Wales, UK, Ernest Choi, his supervisor from Wales, UK, Caitlin, who is our fellow from Australia, Mary Cowan, patient research partner who will be leading off this morning's discussion, Lee Simon, myself, and Laura Maxwell. So, Mary, I should just, I'll list these very quickly. What we're going to be doing is talking about pain overall, but importantly, distinguishing between various types of pain. You'll learn about nociceptive, neuropathic, and nociplastic pain, and then discuss the whole issue that came up quite strongly yesterday about whether we can create a simple tool to measure pain across all rheumatology indications, or need to take in some way take into account some of these complex variations on pain type. So thank you.
Excuse the laptop, everybody. I have the lovely, thank you. And excuse the snotty nose as well. Well, excellent, I have a snotty nose. So good morning, everybody, and welcome to our workshop. Really excited to be here today with you. I wanted to kick off, first of all, about the importance of understanding pain from a patient perspective. I know firsthand that pain is a subjective and highly individualized experience. What one person might describe as unbearable pain could be managed really well by somebody else. This variability in pain experiences between individuals highlights the real importance of understanding and acknowledging each patient's unique individual perspectives. So core outcome set development, which involves identifying key outcomes that matter to patients, can further help capture these. By truly listening to patients and considering our perspectives on pain, core outcome set developers ensure their sets are relevant, promote patient-centered care, improve communication, broadens perspectives, but most importantly, empowers patients. And I think that empowerment is really, really important. So, what's the impact of pain on the quality of life for people like me living with a rheumatic disease? Well, speaking from my own experience of living with arthritis, I can attest to the profound impact the pain has had on multiple aspects of my life, and very similar to many of you in the room as well. It can affect how we move, how we think, sleep, and feel, along with our ability to work and spend time with our loved ones. Pain can affect our ability to perform daily activities, our emotional well-being, and our relationships with others. As someone dealing with pain, I find it increasingly challenging to engage in everyday tasks, maintain those social connections, and achieve a good night's sleep. And actually, in fact, since I've been here, I've been lucky to have slept more than 4 hours every night. All of these factors can significantly diminish our overall quality of life, making it crucial for core outcome set developers to consider our experiences and address our needs effectively. So when you live with pain, the only one who knows how much it hurts is yourself. Pain can be hard to describe because it's invisible and it's very personal as well. And the picture in the background of my slide here is a painting called An Angry Joint by a wonderful Canadian artist called Otto Kamenetsky, and I do apologise if I pronounced his name wrongly. and he lives with RA. And for me, that painting really sums up what it's like living with pain. Pain is complex. Why do some people feel pain long after they've healed? How can people feel pain from limbs that have been amputated? And what makes people with horrific injuries sometimes insensitive to pain as well? The truth is, the pain is far from straightforward, and we'll hear about that today. As I wrap up, I want to share some quotes with you from a survey we did with PRPs when we asked what people with mild or moderate outcomes, what that would mean for them in managing their pain. And here's just a few of those quotes. To sleep so much better and do so much more to help my mood and not be so down on myself and feel useless. Why should we ever feel useless? Instead of being in pain, I would have had more presence and clarity. I could do more gardening and housework without aggravating painful joints. This result would have a positive effect on my mental health, and that's just by a mild improvement on their pain. Pain affects everyday life, and it's very hard to live with. Any decrease in pain is meaningful, no matter how little it is. I'd be able to do many of the things around my home and in life that I can't do now because of the pain. Understanding, treating, and managing pain is among one of the greatest challenges facing our societies today. The challenge is huge, but so is the prize in minimising the daily impact of pain of lives of people like me and many others out there living with arthritis. I couldn't compete with Geordie's t-shirt, I'm afraid, but I hope you join me today in inciting this session to rebellion and taking us forward to make a difference to the lives of all patients experiencing persistent pain. Thank you.
Thank you very much, Mary. That was wonderful. Okay, so here's a cartoon that gets across the point that we process pain at a central level. For example, if you pass your finger through a flame, there's a instant message that's sent through the dorsal horn up through the spinal cord to the pain processing centers in the brain, including the prefrontal cortex, the insula, and so forth. And there's a complex interplay between the processing of pain between various emotional centers in the brain as well. There are neurotransmitters that facilitate this transmission that are noted on the left. And on the right, there is a compensatory or inhibitory pathway that modulates pain experience. These, in all of us, or most of us, tend to be in balance unless we have a chronic condition, chronic autoimmune condition, chronic pain condition, which leads to an excess of the facilitatory pathway and a diminishment of the inhibitory pathway neurotransmitters, which is partly gene-related. The IASP, the International Association for the Study of Pain, has come out with three basic types of buckets that we put pain type into. Peripheral or nociceptive pain, and classic examples of that are osteoarthritis or rheumatoid arthritis, neuropathic pain where there's actually disease of the nerve itself, such as diabetic peripheral neuropathy, and then central or nociplastic pain, in which there are numerous examples noted here, including what we call fibromyalgia, irritable bowel or irritable bladder syndrome, temporomandibular disorder, and so on. Here are the specific definitions for these three types of pain. Nociceptive being pain that arises from actual or threatened damage to non-neural tissue and is due to the activation of nociceptors. So this is what we mainly think about when we're thinking about our patients with rheumatoid arthritis, inflammatory activity, swollen joints, etc. Normal nerves, but abnormal tissue inflammation, which is exciting those nerves to transmit pain. Neuropathic pain is pain caused by a lesion or disease of the somatosensory nervous system. And then nociplastic pain was the terminology incorporated in 2016 to replace the phrase central sensitization pain. So you'll see various terms thrown around: central sensitization, nociplastic pain, fibromyalgia, and so forth. These are all overlapping categories. Pain that arises from altered nociception despite no clear evidence for disease or lesion of the somatosensory system causing the pain. And then this is often influenced by features such as fatigue, cognitive disturbance, and so forth. They tend to get bundled into one. Oftentimes, our patients are experiencing a mixture of these forms of pain. And we define fibromyalgia as nociplastic pain plus fatigue, sleep disturbance, dyscognition, and additional somatic symptoms. Here are a list of the types of things that we typically measure in a clinical trial. Usually pain is measured by a simple VAS or NRS scale. There are anchors from none to worst. There's a certain time span that the patient is asked to assess over the course of the last 24 hours, right now, or over the last 7 days, which the FDA happens to like. There was quite a bit of debate yesterday in our group about should it be a reflection of the worst pain that the patient is experiencing or average pain, with Peter and Bing getting an earful about, well, maybe it should be focused on worst rather than average, which it is currently. And there are also some composite measures that are out there, such as the brief pain inventory or the PROMIS pain interference and intensity scales. However, none of these are able to distinguish nociceptive from neuropathic from nociplastic pain. And the question is, does it matter? So I'd like to just take the next few slides to investigate whether it does matter. So first of all, here is a figure that suggests, that points out the fact that much of our pain experience is based on what our genetic profile is. So there are a number of genes that are noted at the bottom of this slide, which, depending on the particular presence of these genes in you, predict more or less whether or not at some point in your life you may develop a chronic pain condition such as nociplastic pain. And this is going to be influenced by many factors, including, do you have an autoimmune disease? Do you have depression? What was your upbringing like in terms of your childhood, embraced by your parents or not? And then factors that are current that influence whether or not you have an ongoing persistent pain condition that has a life unto itself. This is an example of a mediation analysis of pain that was done with the drug tofacitinib in psoriatic arthritis, and what was found was that about 3/4, a little bit less than 3/4 of the pain was mediated by inflammation, as reflected in measures such as CRP, enthesitis, itch. But there was also a 30% direct effect of the drug on pain reduction, presumably a central diminishment of pain. Here's a table that summarizes the finding of fibromyalgia or nociplastic pain in many of our conditions. And as you can see, there's quite a range. In lupus studies, ranging from 10% of patients up to 65% of patients in one study. In rheumatoid arthritis, just shy of 20%. In Sjogren's syndrome, one study done out of Oregon found that 50% of patients had fibromyalgia in this large community cohort. Osteoarthritis, a little bit less. And in the spondyloarthritis and psoriatic conditions, various studies that suggest that the figure, again, is just shy of 20%. this is different than in the general population where we find fibromyalgia be present in 2 to 4% of patients. So there's something about having a chronic autoimmune disease that contributes to having parallel, ongoing nociplastic pain. Now we get toward, does it matter? Here is a study of rheumatoid arthritis patients in which about 20% were considered to have fibromyalgia. And as you can see in the table on the right, various measures of rheumatoid arthritis that have subjective elements within them, such as the DAS28, the SDI, CDI, even the HAQ score, are all twice as severe in the patients who have fibromyalgia along with their rheumatoid arthritis versus those that aren't considered to have concomitant fibromyalgia. Now, there are a number of ways of assessing for fibromyalgia, including the old 1990 criteria, but more current questionnaires that are given to patients, including the Chronic Widespread Pain Index, the Pain Detect questionnaire, the Fibromyalgia Rapid Screening Tool, and something called the Central Sensitization Index. There are also quantitative measures that are done in research studies, including fMRI scans. And one of the findings that we've had in fMRI is that patients with fibromyalgia, with the investigator uses a tool known as a thumb smasher, where you put a certain amount of pressure on the thumb and then ask the patient, do you have pain? And then look at the fMRI to see where pain is being processed in the brain. We learned that fibromyalgia patients indeed have light up in the brain processing areas where pain should be interrogated, and find that that they have much lower threshold for experiencing pain than in a normal individual. We've also learned from fMRI scanning that patients who have fibromyalgia or nociplastic pain tend to have a constant activity of something called the default mode network. So instead of having periods of where that default mode network neural wiring goes into rest, fibromyalgia patients tend to have this going all the time. So we've learned from those kinds of studies that indeed there is a difference in pain experience in those who have chronic nociplastic pain. Here is a tool that was developed by Fred Wolf called the Widespread Pain Index and Symptom Severity Scale, in which we ask patients, where do you have pain in your body? And the more places that they have pain, and then as well have symptoms of fatigue, sleep disturbance, cognitive disturbance, and other symptoms, if they score high, then we know that they have a tendency toward having fibromyalgia or nociplastic pain. Here's a study in which, in the CorEvitas registry, used to be known as the Corona registry, we asked about this in a group of psoriatic arthritis patients. So a total of 1,800 patients, a portion of whom, all of whom were given the Widespread Pain Index and Symptom Severity Scale. And in the lower left, you can see that in the gray are individuals who were not considered to have fibromyalgia, and in blue, the individuals who were considered to have fibromyalgia according to this WPI-SSS scale. And again, consistent with other studies, it shows that the outcome measures we use to measure the disease are twice as severe in those patients with concomitant fibromyalgia. On the right, I've put what is called a set of lowest curves. And the key thing to see there is it's not a black and white thing. Either you're in the fibromyalgia bucket or you're out of it. But it's a continuous curve. And so there may be moments where if the patient is well treated, they're on the lower end of this curve, but if they're inadequately treated, they will be high on this fibromyalgia curve, which then influences their disease severity outcome measures. So it does appear to matter. And if, for example, a drug developer does a phase 2 trial in rheumatoid arthritis, let's say, and half of the population that they end up studying in this proof of concept trial scores high on the WPI-SSS, i.e. having fibromyalgia, then that's going to throw off their ability to discern whether the drug really is working or not. So one of the things that we've been encouraging is, especially in phase 2, when you want to really understand the the true biology of your drug, that you try to exclude individuals who have a high tendency towards central sensitization. But in phase 3, since it's more what you want to see is what it's going to be like in the actual population in which we treat patients, that you may want to keep those patients in, but then stratify according to whether or not they have high degrees of central sensitization versus low. And this is also important for clinicians, because if they have a patient in front of them that has a normal CRP, no swollen joints, but a high level of pain, fatigue, sleep disturbance, it makes you pause in terms of switching from one immunomodulatory drug to another. Here are some of the other measures that were mentioned. The first questionnaire, the Pain Detect questionnaire, which was originally developed to study neuropathic pain, and then something called the Central Sensitization Inventory. When these have been applied in rheumatic diseases, they have found typically that anywhere from 20 to 30% of our patient population has this particular phenomenon as an issue. So with that, I'm going to turn over to our fellow, Tim Pickles, who's going to drill down and show some of the work that they've been doing in Wales in this regard. And then Ernest will guide us through how we're going to tackle these questions in the breakout groups. Thank you.
Everyone, I'm going to jump straight into some analysis we've been doing at Cardiff University. We had, we had a data set of 166. Any better? Had a data set of 166 patients, about 30% with rheumatoid arthritis and 70% with psoriatic arthritis. About roughly even split male, female, mean age of 54 and disease duration around 12 years. And these came from a project that Ernest had been completing with some students at Cardiff University on chronic pain phenotyping. So as well as having all these patients, we collected a lot of data, lots of things that have just been mentioned, the hack, Pain Detect, which as well as measuring can also split patients up into neuropathic and nociceptive pain, the brief pain inventory looking at severity and interference, the measures for fibromyalgia diagnoses, and which we see, as you said, about 28% with fibromyalgia, and also an objective measure of pain, the pain pressure threshold. So this is what we want to look at with these data. The difference between those with and without fibromyalgia on the pain pressure threshold, the correlations between all of these measures, the differences on pain pressure threshold between the people in the various Pain Detect categories, and also the alignment of the Pain Detect categories, those with fibromyalgia. So lots of numbers on this slide, don't worry about it too much. But basically what we see here is there is no particular difference in pain pressure threshold between those with and without fibromyalgia. Here are the correlations between all of the measures. The important one there is in bold in the middle, that we see that the brief pain inventory severity and interference measures correlate very highly, suggesting they might be measuring a roughly similar construct. Other values of interest on here as well are that the severity and interference measures correlate moderately with the other measures and very low with the pain pressure threshold that we see at the bottom. So I'll come back to what all that means at the end. For pain pressure threshold split up by the Pain Detect categories, again, a whole lot of numbers kicking on there, but this important slide here shows pain pressure threshold is much lower in those with neuropathic pain compared to those with nociceptive pain. And it does look like there's possibly a difference between nociceptive pain and this bracket of unclear pain, but that's not quite as obvious, not quite reaching statistical significance. So we see nociceptive pain and neuropathic pain are different. And then lastly, we aligned the pain detect categories, you can see on the left, with fibromyalgia diagnosis on the top. And what we see is that neuropathic pain is more common in those with fibromyalgia. So just to go over those points again, severity and interference in the brief pain inventory are highly correlated, but those correlations with the other measures are much lower, sort of in the moderate range, and also correlation with pain pressure threshold is very low. PPT, pain pressure threshold, was much lower in patients with neuropathic pain compared to those with nociceptive pain, and also neuropathic pain is more common in patients with fibromyalgia. So this all leads to this diagram I showed you in the talk on Tuesday. It's brilliantly drawn by Ernest, that inflammatory arthritis like rheumatoid arthritis and psoriatic arthritis can cause both nociceptive and central pain, and that central pain can be inflated by concomitant diseases like fibromyalgia. So for nociceptive pain, we need to use something like a disease-specific measure like a swollen joint count, and for central pain, we should use something more objective like pain pressure threshold, or perhaps the patient-reported outcome measure pain detect, and that both of these types of pain are encompassed within measures for severity and interference, which we can use from the brief pain inventory. So that's everything from me. On to Ernest.
Now, the breakout room group format is very similar to what you have done yesterday, with just some very minor differences. So within your app, you should receive a notification of where you should be going into which room for the breakout group. In each room, there will be a facilitator who would give you an introduction about the discussion. Then you will reflect on the questions that we have posted and want your feedback on. You will share that with your neighbors, and then there will be a 13-minute discussion of the whole group on the topic. And then all of you, after the breakout group finishes, will come back here so that the reporter in each room will then report back your feedback, and then we will go into the polling questions. The questions that we want your feedback on are listed on this slide. Do we need to assess and or select patients by the type of pain in clinical trials? Do we need to know the type of pain to ensure that treatment or medication will be effective in a clinical trial? Do the types of pain affect the validity or the truth of an instrument, such as the joint count, pain score, pain interference, and remission? And do the type of pain affect the sensitivity, that is the extent of our measurement too, will reflect the efficacy of treatment? So those are the questions we'd like your feedback on. Unless you have any burning question, then we can go to each of the breakout groups, and I look forward to all your contributions and comments. So thank you very much for all your contributions at the breakout group. I definitely thoroughly enjoy all the discussion. So First, we have Lara.
Hello, everybody. So we had 5 patients in our room and 6 other stakeholders, so really nice split and mix, and we had fantastic discussion with Ernest. We're all very happy to have him as our content expert and taking the opportunity to ask him many questions. So for question 1, we talked about, well, it really depends on the type of trial and the mechanism of action that's being tested, especially in like early phase 2 trials where you're looking to see if the drug actually works. But then if you're doing that by restricting to the type of pain, then you might be missing out on those people that have all 3 types of pain. And they're going to be falling through the gaps, and they're the ones that often have the greatest need. So we have to be very careful about how we manage that. And then the next question about affecting the validity, well, it might not matter about the type of pain if the goal is just to measure pain intensity. A pain intensity instrument might match the domain regardless of the type of pain that you have. However, remission could be a problem because achieving remission in a nociplastic pain may never happen. And tender joint count could be different depending on the type of pain. And also whether or not we're talking about children versus adults. Children and the different types of inflammation there might affect the validity of the instrument. So those are our key points. Thank you.
Thank you. Next, we have Caitlin.
So I'm reporting back from group 3, and we had an excellent discussion that there's no chance I'm going to capture it all in 2 minutes, but I'll do my best. So for the first question, do we need to select patients by the type of pain for clinical trials? We thought, yes, in general, just because the way things are going, everything's becoming more tailored and personalised, and so we need our evidence to discriminate on that more specific level as well. But it would depend, of course, if the treatment being tested is supposed to target a specific type of pain, or if not, then it's probably less important. A challenge that Lara also mentioned was that the risk of then discriminating people that have either multiple types of pain or just are unable to discriminate which type of pain they have. And if we have strict criteria in trials, there's going to be a large chunk of people that are excluded. For the second question, do we need to know about the type of pain for clinical trials? Yes, in general, because it would reduce research waste. For trials that are meant to be testing specific treatments for specific pain types, there's no point wasting other people's time by recruiting them into those trials. Another challenge with this is that often people are misdiagnosed or their type of pain is unknown. Again, they can't distinguish that type of pain, or that it changes over time. You know, what was originally nociceptive pain might become nociplastic pain even in the duration of a trial, depending on how long it is. Another point that was brought up was, the 3 different mechanisms of pain do make a difference, but there's other things like the location of pain might affect severity and interference. A good quote was, the nearer the brain, the worse the pain. I don't know if others can relate to that. And also there's cultural differences in how pain is understood and reported, so it might be even more complex than the 3 complex types of pain. The third question was about the validity of the instrument, and our group thought in general that the generic pain scales can capture all 3 types of pain, but the effects are going to be smaller when the treatment is just targeting one of those types. For example, if someone has all 3, one of them might be treated, the other 2 are still there, and in some cases can become louder because the distraction of that one of those types of pain is reduced. So overall, their say in a VAS pain scale might not change, even though that treatment was effective. Another point was just feasibility. That's an important part of the OMERACT filter, and there was some concern about introducing multiple outcome measures for multiple types of pain, just with how feasible it is to ask patients to be filling, more than one survey out. And just very briefly for the fourth question is, does the type of pain affect the severity of the instrument? There was resounding yes. I don't know that we had any sort of solutions for that, but yes, it definitely will affect it. Thanks.
Thank you very much for that. Next is Robin.
Hello, thanks for having me. I have conflicts. I come from Arkansas, that's my first point of view, and next is we were 16 individuals in there, 1/4 being patient partners. My conflict here is that I'm also a member of the Contextual Factors Working Group, and I'm highly excited about this exercise, so now you're warned. Question number 1, I phrase it, think about it now after the feedback even more as whether phenotype of pain should be part of deselecting patients in coming trials. Meaning you have patients with these different phenotypes of pain or types of pain, whether we as a group thought that we could use it to select or deselect some patients, because that's probably happening as we speak. Most of the people in the room, if not all, agreed that we should probably not use it for eligibility criteria. We would rather see all patients being included, and that leads to I'll just make sure. Yes, so not deselect, but measure it. And that leads to question number 2, which would be whether we would like to see some more pragmatic trials in terms of pain phenotypes, meaning include all, whatever that means. It's difficult to define pragmatic trials, by the way, but rather not deselect. And then people mentioned, it's important that we apply stratification. Some argued for stratified randomization so that these groups are equally distributed across these phenotypes are equally distributed across the groups. And some even worried about some statistical nerdery about whether there's enough statistical power to detect later in whatever test people would do. And then the third one, I figured that was a measurement affecting contextual factor. Yeah. That is whether some pain phenotype could interfere with the measurements that we already use, meaning are they still valid or trustworthy, or whether the measurements are good enough. Some people worried that now that we are looking into this and opening up the can of worms, and talking about phenotypes all over, we would need potentially to reinvent some measurements that we use all the time, because they might not have been validated across all these pain phenotypes. Finally, the fourth one, also highly exciting, effect-modifying contextual factors. How should trialists collect these pain phenotypes at baseline? That was a frequently raised question across all the 4 questions. Phenomenon. People worry, but we were able to reassure them that we consider this a domain discussion at present. So which of the data we were not assured yet. Some members argued that it could be difficult if these scales are continuous by nature rather than falling into categories. So because they are highly likely not linear, was being mentioned. And then finally, and this goes back to the statistical mind of mine, there should definitely be some statistical test for interaction between these phenotypes and the group applied in RCT. And again, the power consideration was taken up. And as a final advertisement for the Contextual Factors Working Group, we do know that, but please start doing more of these stratified analyses. And please come to Rio Grande tomorrow at 8 o'clock, and then I'll shut up.
Okay. Thank you, Robin. I'm signed up for the contextual factor group after that contribution. Thank you. So last but not least, we have Melissa.
All right, hi everyone. We had a very lively discussion. We had 19 people in our group with 3 PRPs. So the first question, do we need to assess and or select patients by the type of pain in clinical trials? So we acknowledge that there is value in doing this, understanding that if we have a heterogeneous population, it could dilute the results or affect the results, but also that some patients may be misclassified up front or potentially change over time. And then we also made comments about, well, this could also depend on what is your primary outcome that you're measuring. Is pain part of an overall composite score versus is it the primary outcome? And this may also affect whether or not you need to assess or select these patients for clinical trials. For question 2, we had a lot of great points for this one as well. Do we need to know the types of pain to ensure that the treatment or medication will be effective? So a little bit of mixed. Yes, some people said, and we can stratify by the types of pain. In clinical trials, are we missing patients who need treatment? And some concerns that therapies may not be able to fully differentiate between placebo effect, and some phase 2 studies have already shown that due to a pain component. However, also no, we can't really, we have a hard time ourselves just really differentiating between the types of pain, from a provider's perspective and sometimes from a patient perspective. It was also brought up that there are some challenges with what we called more the average physician outside of the OMERACT group, and how they may classify the pain in their patients, and that there may be some implicit and explicit biases with this. One particular example was brought up by gender specifically. This could also depend on the type of clinical trial, the type of the specific phase that you're in, and the treatment choice. And then one of the concerns about trying to stratify is that this can bring up challenges with needing to increase the number for power and also increase cost. All right. Sorry. So for question 3, do the types of pain affect the validity of the instrument? We also had some mixed opinions on this as well too, yeses and nos. If a patient is primarily central sensitization or nocioplastic pain, then yes, the pain is there in the patient, but when assessing, the truth of the either the instrument or the drug, you really need to show a change. There are different instruments for different pain, and if you use the wrong instrument for the different type of pain, then it'll affect the validity. But also, in the end, comments were brought up that, well, in the end, pain is pain for the patient, and the pain will always be in the patient. So there are some challenges, again, with really differentiating between the different types of pain. Some patients have a hard time doing this, and providers. And then last, where's my number 4? There we go. So last, for number 4, do the types of pain affect the sensitivity of the instrument? Overall, we felt yes. Not only just the type of pain, but there's also some other components of pain that can affect this as well too. The duration, the frequency, depending on what status of disease activity the patient may be in, if they're in a mild flare or severe flare. And if we want to have a good discriminatory ability of responsiveness, then yes, we would want to evaluate the different types of pain. So yes, overall, we felt like it could affect it. Thank you.
Thank you very much for all your comments and contributions. We really value them. So we have a Q&A session now. There will be roving mics. So if you have questions, do you want to put up your hands? I don't see any hands. So, okay. Any questions?
Who's first?
No. No. I don't see any hands.
Oh my goodness.
Wow. Maybe we have answered all your
Everyone's
questions.
shy this morning.
Yeah. So are we all ready to answer the polling questions? If you don't have any questions.
Oh, Pam has a question.
Oh, Pam has a question.
Thank you.
It isn't a question, it's just a thank you. That was a really great session.
Oh, thank you. Thank you.
Thank you, Pam.
So could I have a microphone here?
You need a mic? Microphone's not on.
So just a comment. I understand from the first group the sensitivity about deselecting patients, and that's a word that sounds harsh. But I'm also aware of trials in phase 2 where there are very few patients involved, and you're really just wanting to answer an immunobiologic question. I think it's legitimate to deselect, or in our group, one of the points that was made was just base it on numbers. If a patient, you don't try to tell the patient, well, because you have fibromyalgia, you're not eligible. That would make them feel very awful. But just saying we're trying to test and have certain numbers and so forth from these questionnaires that are patient-reported outcome measures. But then I think that in phase 3, embrace all comers in order to really see what your drug is going to do in the real world. And of course, once the drug is approved. But that's a very sensitive stage, phase 2, because I've seen drugs die simply because they couldn't show differentiation from placebo or show an adequate effect size to move on into phase 3. And that, I think that's where it's very, very important.
Great, thank you for that comment, Phil. So we can, you can answer your polling question on the app now. The first question, do the varied types of pain affect the validity, truth of the instrument, like joint count, pain score, pain interference, or remission? I think if it's maybe, I think if you think that it changed the majority, then go for yes. If you only think that the impact is small, then you can go for no.
Bing, do you want to add a few more points to your point that you're trying to make there? Can we get a microphone to Bing?
Yeah.
I'm thinking more, is it on? I'm thinking more sort of conceptually about pain interference as being a little bit different from some of those others, in that the types of pain, I can see, that it could or could not influence pain interference depending on how pain interference was interpreted on the questionnaire.
I get that's one level. I think if at this moment in time, I think our position about pain interference is a domain but not an outcome measure at this moment. Right? We don't have an agreed instrument to do pain interference as such. So I guess that is an exception. Though that point is well taken. So maybe we take pain interference out of that and look at the other, which are standard outcome measure we use in many of our arthritis trials. Pain interference is not included in our arthritis trials, of course. Not yet. Not yet.
Anyone else with a question?
Okay, great. Thank you. Okay, great. 8. So the second question is, do the very types of pain affect the sensitivity, the extent of change of the instruments that measure the efficacy of a treatment in a clinical trial? Yes or no, please? Wow, okay. Oh, getting very close to 100%. Okay, next question. Do we need to assess or select patients by the types of pain in clinical trials? Maybe this will be more controversial.
Yep,
Oh,
one
that's a
sec.
question.
Grayson?
Grayson.
Thank you.
Assess and select are two very different things. I think all of us that are PRPs all just kind of looked at each other like, who's going to say it? So I don't know that I would say yes to this, with this being an and or listed here. I think it needs to be either assess or select.
Okay.
For us to actually give a concrete answer to that.
That's a great point. Is there any way at this juncture? Oh, great. Sean is saying yes. We could have 2 questions.
One, assess, and then second question, select.
Yes.
Great. Should we do that? Perfect.
Thanks, Shauna.
And then the next
And
one
then
is on
and then select. Okay. Still have 80% just to assess patient by the type of pain in clinical trial. Then the next question will be to select. Well, actually getting more and more. Okay, should we move to the next question, which is about selecting patients by the type of pain?
in your apps.
Okay. So this is the answer to select patient by the type of pain. Am I interpreting that right, Shauna?
Yeah,
Yeah. Okay.
it's
Great.
in the... Yeah, perfect.
Okay. So we actually got quite a lot of agreement on these questions. I think the last question's coming up. Do we have the last question? Or was there only 3?
No, there's a fourth question.
There's a 4th question, I think. Okay, so this is about selecting patient. We have less support for this. Okay. Thank you. The last question, do you believe using a single pain measurement scale, be it numeric rating scale or VAS, is sufficient to assess nociceptive, neuropathic, and nociplastic pain, or should we combine general pain intensity scales with more specific and multi-dimensional tools for comprehensive evaluation? And there are 3 options there. Option 1 is a single pain measurement scale is sufficient. Option 2 is combining the general pain intensity with specific and multi-dimensional assessment tool. And C is we haven't given you enough information to answer that question.
Martin.
Martin, coming with the mic.
Can I just ask a question? Because I think to answer the question and get more, real information, I think you should specify a little bit more what the setting is of using either a single pain or something else. In what setting? Are we talking early phase 2? Are we talking phase 3? Are we talking rheumatology, arthritis trials? Are we talking specific pain trials? What are we talking about here?
So I assume the context of this question is in the principle of sort of the OMERACT spirit. This is for clinical trial, and since the core set isn't different for phase 2 and 3, it has to be covering all phases of the trial.
Okay, but is it for trials on pain, or is it for trial on another health condition?
Trials in arthritis.
In arthritis?
Yeah.
Okay, thank you.
Yep, over there.
Okay, so there's a lot more support for combining the general pain intensity with more specific instrument. But there are also quite a lot of you who feel that you need a lot more work to be done, perhaps to optimize the two. Do you think that I've summarized that feeling correctly? Yes. Okay, fantastic. Thank you very much for all your input.
Yes.
Enjoy your lunch. I've really enjoyed this session. Thank you for all your support.